So Katie, the second elephant in the room is which PARP? So it's unprecedented where we have medications with virtually identical labels. We have olaparib, rucaparib, and niraparib in patients that respond to second-line platinum. Tell me the things that you consider in choosing one PARP inhibitor over another. And I apologize for putting you on the spot, but that's what these guys want to know.
I think that, what do you think about when you're choosing a medication? You think about efficacy, you think about side effects. So what we know, again, from a lot of data across all three PARP inhibitors is that really these are all very good drugs. There's not, of the three of them, a best PARP and a least best PARP. They all work, as best as we can tell, equally well. When you look at the BRCA hazard ratios for maintenance and for rucaparib, and actually all three of them now, the Quadra data will be out soon, the BRCA response rates in treatment, the maintenance hazard ratios are almost identical. If you look at HRD positive in the maintenance, they're almost identical. So the efficacy of all three of them is very, very similar across treatment lines. So I don't really think you can pick based on that. Prior to the weights and plates analysis, the radar analysis with niraparib, which was a response to the high prevalence of incidence of thrombocytopenia in NOVA, I think that was sort of a way to discriminate on an adverse event standpoint between the three PARP inhibitors, where the other two didn't have that high-grade toxicity. Now, and you presented the PRIMA data, which is frontline, with that modification in from the beginning, not a reaction to the platelets, but from the beginning, we individualized dosing and have demonstrated that the hematologic toxicities look really, again, if you compare it to SOLO-1, which is the other frontline, it's identical. I don't know that you can discriminate them based on key adverse events. There are some differences. Niraparib has some hypertension and thrombocytopenia. Rucaparib has the transaminase elevation. There's some anemia with SOLO-1, but none of them really kind of make you pick one over the other. I think it comes down, honestly, to what you're comfortable with. So if you are comfortable with olaparib, use olaparib. If you are comfortable with niraparib, use olaparib or niraparib, because that's what's going to help your patient stay on longer, is your familiarity and your ability to set expectations, manage side effects, and help her feel comfortable that she's on the right medication. If you're kind of guessing between three PARPs.
So lots of talking points. You said activity and toxicity, and then you said that the most common dose of niraparib was 200, and you can get there faster by starting at 200 if the patient weighs less than 77 kilograms, or got to have both a baseline platelet count of 150.
Right.
And once you personalize proactively the dose, then the toxicities are more similar. And then you said activity, and then you added a third, familiarity. There are others, but so Brian, what do you think about this idea that in the non-BRCA patient, which is most patients, that niraparib is more lipophilic and has higher intratumoral concentrations? That's why it's once daily. That maybe, and that NOVA was the only trial really to isolate the treatment effect in the non-BRCA cohort. Does that resonate with you? Is there a story there? I'm not asking you whether niraparib is your choice, but is there a story there?
Yeah, no, I mean, as far as my choice, I use all three based on the indications that they're approved for. As far as, the niraparib data is broader in all comers, allowing for the BRCA wild type. I will use it perhaps there more in that setting, but I'm not sure of the right answer. I'm not sure if it's a lipophilic absorption within the cell or not, to be honest with you. But it's familiarity, the side effect profile. I really enjoyed the data that came out at this year's SGO meeting, eliminating that toxicity that we saw, getting rid of the thrombocytopenia with the more, but it's worth saying again, based on the weight and the platelet count, we're able to eliminate that with the 200 dose.
So we have three things. We have activity, toxicity, and familiarity. How about convenience? So rucaparib and olaparib are twice daily. niraparib is once daily. Is there a story there?
Yeah, I think there is. I think maintenance and treatment are different timelines in patients' lives. I think women in the maintenance setting do not accept as much side effects or inconvenience as they will in treatment, even though we all know it's truly treatment, but not for them in their point of their treatment life. So I think that once a day is convenient. I think the weights and plates changed how women tolerate it. So I think in the maintenance setting, it has to be something that has low side effect profile, convenient, doesn't disrupt their life. But again, to me, it all comes down to this personalized treatment. Somebody who has great metastatic disease, I will use niraparib because I see data about crossing the blood-brain barrier with niraparib. Other women who have baseline lower platelets and I know have had trouble before with thrombocytopenia, I won't. But I also, just like Brian, I believe in PARP after PARP after PARP. So all my women have been on all 3 PARPs, if not 6 times,
Leave
over
no
and
one
over again.
behind.
Right.
So activity, toxicity, familiarity, convenience. At this year's SGO, we had a whole session on cost and financial toxicity. Katie, how much does cost of the 3 different PARP inhibitors play into the decision process?
To be perfectly honest, for me right now, it does not come into play really because it's just not, and I know people are gonna shoot daggers at me, but I mean, I want women to live longer and it costs what it costs, and that's sort of gonna work out in the general health economics world that is not me. I'm here to take care of patients and I want them to have the best drugs. And truthfully, between the 3 PARP inhibitors, and I use all 3 as well, the patient assistance programs are so robust that.
Do you think they're the same?
I think that they're different, but they've all been accommodating to all of my patients. Like I haven't had a single patient who couldn't get a PARP. I have patients on PARP. I mean, I live in Oklahoma where I don't have a lot of patients that can walk in with cash. I mean, they just are kind of hardworking folk that can't even afford a $200 copay is too much money. And they can get this drug. So, and we have financial teams. I mean, I have resources that I know a lot of oncologists don't have because I'm at a cancer center. So we have financial navigators that help get them to that point. But we've been able to successfully even get our patients with state insurance PARPs.
So Brian, how inappropriate would it be to say, as you walk out of the room with a patient who responded second line, who needs PARP maintenance, because she says it's virtually unethical, at least not to talk about it,
And give it.
and tell your nurse practitioner, or PA, whoever, and say, just give her the one that has the lowest copay. Because she admitted they're not the same, and I don't think they are the same either. What would be wrong with that approach?
I love this conversation. This is the first time in G1 oncology that we've had 3 drugs with the same class approved. Normally we have to think about the class and the efficacy, and we don't have to worry about this problem. So now we're like a cardiologist worrying about which antihypertensive medicine to give. We have a whole plethora to choose from. So I love the fact that we're having this conversation. I would really, compliment the 3 PARPs that are approved. The patient assistance programs for all 3 of them have really, in my experience, have been wonderful and have helped patients. When we choose a drug, helps the patient get the drug. So, I'm not choosing one or the other. All 3 of them are great. So, truthfully, Brad, I've never had that problem with which one has a higher copay or not. And while the nurse practitioners are helping the patient get the one that we're prescribing, they're not coming back with that issue.
Elena, what are your comments on cost?
Similar. I just like Katie said, I believe in it from the society perspective, but I think at this point it is such an advantage that we have had for the first time, really in a long, long time, in improving women's lives and survival. I don't think there's a question.